Good, thanks Anita. The old stalwart's still here. Well done, everybody. You get a brownie point at the end. I don't know if you get CPD for commissioners, but there we are. I think what I want to focus on really is a couple of things. Particularly the work that we're doing in the national programme around CPR, and also what we're going to do in London. And those of you who come from outside London will have experiences in your localities as well. And I've just entitled this Mind the Gaps, Please, because actually where patients are vulnerable is when they're in transition between services. And so that's the area that's particularly important. So this is one of the case stories from the national site, which I'll talk about in a moment, but it's really to frame the issues for you. So Mr. Beat, he's 90, demented gentleman, renal failure, infection, increasingly frail. He could be dying, might not be dying. He's admitted to hospital. He did fine in the first instance, but subsequently had a gut bleed. Everybody had to think about it, decided that actually there was nothing further that ought to be done with this gentleman, and the family were very committed to get him home. So all the arrangements were made. Everybody did very well. There were loads of people actually talking to each other in the hospital. Palliative care was involved, the renal team was involved, etc., etc. But because they said he wasn't dying yet, he was going home to die, and because he didn't have a Category 1 ambulance, they put him into a standard transport vehicle. He had a CPR form with him, and his heart stopped during the journey. That was, by the way, because he died, not because somebody should do something about it. It was considered to be invalid because he had an electronic printout from the hospital. CPR was started by the ambulance transport crew. They weren't a paramedic crew. Whilst they were doing that, they rang 999 to ask for a paramedic crew to arrive, and they duly did so, and they continued CPR despite the presence of this and despite the protests of the family and their level of distress. When the CPR was eventually abandoned, there was the next problem, which is we have a body on our hands now. What are we going to do with it? And so they rang the A&E of the discharging hospital, who told them it's not our problem. So they were unable to take the patient back to the sending hospital. The family were too distressed to consider anything to do with the body going on to the home for understandable reasons. Nobody discussed with them the possibility that actually if he was going home to die, he could actually die in transit. And thirdly, because no one could make a decision, the guys decided that they'd call the police for advice. And the police, as soon as they discovered that the patient was, quote, on a morphine pump, he wasn't actually, he was having antiemetics, but that's beside the point. He had a syringe driver, and that was a good enough reason for them to decide that they should investigate this death. And he then subsequently ended up in the coroner's mortuary and would have had a post-mortem had we not been able to intervene. So that is an example from London. It's an example from London in the last year. But there are many other examples in London, and every ambulance service around the country to whom I've spoken will tell you that they've had this or a similar experience on many occasions in the previous few years. So this is not an isolated event. When we looked back, communication had actually been good between the clinicians, because we've a lot of the hospital work in London is quite good now. There is communication between teams, but hospitals seem to think they live in a world of their own, and they don't see how they connect with that strange place out there called the community. And it was forgotten that they had to communicate with the services. Because he was not dying yet and wasn't on an LCP or the equivalent, that he wasn't given a Category 1 ambulance. He basically had a transport ambulance, and those staff simply did not have the skills to address the problem, certainly not to come to a judgment. Nobody had told them or the London Ambulance Service that the patient was at risk of dying, and these guys perfectly understandably believed that this was invalid once the patient had left the hospital. And the reason that they do that is that if they don't, then they themselves can be up for discipline as a result of their actions. Mentioned that. Interestingly, this was an area of London where CMC was in use. So the electronic register wasn't triggered. Now, the reason it wasn't triggered was that it was the wrong ambulance that was sent, but actually it should have been picked up by the 999 ambulance, but there wasn't an address to do with it. It was an ambulance calling an ambulance to assist them. They didn't have a trigger to bring up CMC, okay? So you can see how there are holes in the system, no matter how hard you try, until you actually make sure that there are clear connections. And of course, there were no instructions to the crew what to do in the event of this gentleman's death. The family were ignored. Is that a surprise? And the two justifications or two statements that are enduring is we have to follow procedure, which was the explanation that the crews gave to the family. And they said, yeah, but we just wanted him to have a little bit of dignity, and that was one of the reasons why we wanted him to go home. So that's the kind of problem that we're facing. Now, from a national point of view, I'm charged with developing the web resources for the National End of Life Care Programme, and they should be available by the summer. And the purpose is to meet these needs, and Mr. Beat is a good example of that. The primary objective really is to build confidence and collaboration between organisations. Within organisations, essentially the policies that are in place are going to be appropriate for those organisations, and actually we would not want to interfere with their internal governance processes. But the problem is when you have people moving between them, because they are, as it were, intestate, they are very, very vulnerable. And they're vulnerable not just because the policies change, but because the clinicians are changing. And that then introduces really the next question, because if you look at things like policies, they talk about strange people called responsible clinicians, they talk about appropriate, they talk about communication, and all sorts of things like that. And of course, nobody defines those words. So who is the responsible clinician? Well, when there's a problem, do you know what? We're all advisors. None of us is responsible. And everybody does that kind of thing. So there has to be certain mechanisms within the systems to deal with that. One of the intentions that we have is to try and get CPR decision-making very clearly within clinical pathways rather than where it currently sits now within what we might call governance pathways. Elements, we're not after a unified policy. I don't think that would ever work, certainly in the first instance. We may end up with that one day, but not now. What we can do, however, is we can refresh some of the approaches that have been taken, particularly, for example, in the light of the Mental Capacity Act, in the light of the codes of conduct, relevant care pathways, and the advice and policies that come, principles that have come from the Resuscitation Council and so on. And all of this work is being done alongside the legal eagles, the relevant bodies, the Resuscitation Council, and the various colleges and so on. So everybody is involved in this who have clinical investment. So hopefully what we turn out will at least be satisfactory to practicing clinicians. And after all, that's where the decisions are actually taken. So in the meantime, and actually regardless of how large a population you cover, there will always be a boundary. There will be a boundary between Scotland and England for the simple reason that the law is different in the two countries. There will be a boundary between Wales and England. There will be a boundary between Northern Ireland and England. There will be a boundary in all sorts of ways. So we do have to manage boundaries, no matter how big the group is in which we have commonality. So actually addressing boundaries is not really to do with a unified policy. It's to do with the idea that you have to deal with patients when they're in the gaps. And of course, the gaps, for example, between the health service and the private health service, the gaps between health and social care, the gaps between voluntary sector organisations like the hospices and the NHS, all of these things. There are gaps and there are boundaries everywhere. And one of the feelings that we have collectively is that we probably can, however, have a common template which is instantly recognisable as a CPR document, although that may then be populated by the particular information that is relevant to the organisation or is relevant and appropriate for the transit of a person from A to B. So, for example, you may have slightly different content in a tertiary centre or a teaching hospital or something, or a private hospital, but actually when the person is moving and the details are there, you need instantly to be able to recognise that, and people then need to have the confidence and the appropriate education to be able to take these matters seriously. And all of that will be available in the fullness of time on the National Intelligence Network website. We hope that'll be up and functional, certainly in its first form, by the summer. And within that will be all the principles and stuff behind what happens with CPR, but also a whole selection of materials, educational processes, and so on. But underlying all of this, really, I think, is one of the difficulties that we've got ourselves into, and that is that we are thinking more and more clinically in terms of governance rather than in terms of duty. So I think there's a philosophical issue that we're having trouble with, because governance is an institutional thing and it originates in the law of contract, whereas duty, which is a clinical thing, originates in law and morality, common law and morality, rather than contract law. And as a result, if you originate in contract, then an organisation is dealing with that contract and it's dealing with it as a single entity, and it therefore produces something that applies and serves the needs of that institution. It is intended in a clinical sense to overlap and resonate with clinical duties and vice versa, and by and large the two are the same thing. But of course they're not the same thing when pressures and difficulties arise, because duty is about responsibility and undertakings between individuals. If you like, it's what you would, the sociologists would call the social contract. But it's about responsibilities between people and the duties that flow from that. So it's contextual. It doesn't follow contractual modelling. It follows contextual modelling. It's based on relationship, and it's not based on institutional imperatives. And so if you really default and force governance into its default position, it will default to avoiding blame, whereas, of course, in social duties, the default is to avoid harm. Okay, so that's where you get the bite coming. Now, normally these things are associated together, and there's not a problem between them. It's only when difficulties arise. But one of the things I think that does happen is that clinicians tend to kick against rules, but clinicians take duties and responsibilities very seriously. And so trying to help ourselves as clinicians to move our heads into a different place is as much of a challenge as anything. So what do I mean by a framework? Well, if we're looking at CPR, because of the governance around it, and that was triggered by all sorts of things, and you can read the history of it on the website if you want to, is that it was really because of complaints and the media and all these kinds of things that CPR got shelled out as a big issue for which there had to be governance structures, rather than seeing it as part of something far bigger. And the Mental Capacity Act and the principles of the Resus Council and so on are the two, as it were, principal structures that are relevant. Here you've got the dartboard. It's a slight variation, but it's the standard one of everybody should have the opportunity for care planning, and they don't necessarily need capacity for care planning to take place. They may want to make some advanced care plans, and they will need capacity if they do that as individuals. They may then have outcomes from that according to the Mental Capacity Act, which would be things like, for example, advanced decisions to refuse treatment and other bits of paperwork. And the one that's relevant to us particularly is the CPR form, which historically has been on a piece of paper, but in theory could be available electronically as well. The second area is the whole area of duties of care. And if you look at, this is from the 2012 GMC duty of care document, you will see that this is now becoming part of our duty and responsibility and obligation. So clinicians, as it were, have to take this seriously because of being clinicians rather than having to take it seriously because the institution says so. And that's really rather important. And the two things that are really difficult is how to agree on the responsible clinician and how to agree how you hand over between them. And really that's because we are dealing essentially with an approach. If we're looking at the traffic light model that we often see, healthy and well, years to go, the lights are green. There are some people, however, and may be people in this room, who would say under some circumstances, I don't want to be resuscitated. I don't actually even want to go there. And some of you may fall into that category. However, it starts to become relevant when you hit the periods between the months and weeks and days prior to the fact that you die, when, by the way, you have a cardiorespiratory arrest. So that is necessarily involved in dying. And this is where you end up with some broad clinical realities, and alongside that, the decision-making duties that come with it. And it's where things like, whilst this doesn't refer to amber, I'm using the amber motif as much as anything, because it's in this zone here where things get tricky and where actions need to be taken because risks are starting to rise. And so if you look at, say, between the months and years of long-term conditions or various things such as that, then diseases are becoming less reversible. There may be general care planning that's necessary, and people should certainly be offered it. And I think that as we find the bleed between long-term conditions and end-of-life care increasing, then people are going to be on electronic patient registers of one sort or another, and they need an early opportunity to be part of that if they wish. The next phase, though, is that when people's priorities really start to change and their minds focusing on their individual future, and what they start to think may be different from what we thought they thought or what we assume they're thinking. And this is why you start needing to get information, and better to get it when they have capacity than when they haven't. And that's a driver for the early engagement. And all of this is to do with CPR as much as it's to do with anything else. To make CPR different seems stupid to me. And of course, you've got the risk of dying rising. And then as you get closer to death, then these things start to happen. And necessarily, inevitability gets associated more and more with urgency, and the ability tends to decline. So the more urgent it becomes, if you're leaving it here, the less time there is to decide, or indeed the less capability to decide. So if we start placing CPR in this framework as distinct from a governance framework, then it starts to become a different story. And that's the purpose really of taking that type of approach. Now, you'll be aware of pathways in a different kind of framework. And the reason it's important to commissioning, this sort of profoundly clinical discussion, is that if we don't have this in the standards and expectations of the services from which we're making commissioning decisions, or we're commissioning services, then we are going to have all sorts of problems. And everybody knows that in the longer term conditions, there are trigger points for review and care and treatment. Patients' preferences may change. These could be associated with hospital admissions. They could be associated with clinical markers of disease progression, and so on and so forth. But what happens is that not only do the goals change, but the teams around the patients change, and the responsible clinicians change. So you may suddenly move from a hospital consultant to a community matron, or to a CNS, or to a district nurse. And actually they become the responsible clinician. And the question is, who is it and how do you know? And of course that depends on all sorts of things, because we all talk about the GP at the centre, and that's fair enough. There's lots of social care often going in, but then it depends on what's happening to that person as to how many other groups of punters are involved in this process. And so you get this increasingly complex galaxy of care and need. And so as a result of that, then it's very easy to lose clarity about responsibility, and actually who is the person who has, as it were, the responsibility and duty to make sure that these practical things happen. And you know, there's just an example here. Let's say, for the sake of argument, that's a hospital consultant and that's a GP. Or maybe that is a CNS in a hospital, maybe a site-specific CNS or a cardiac CNS, and this is a district nurse or a community matron. Doesn't matter. But what we do know is there are two places where there's a potential risk, and that is in the hand-on, the handover between the two systems. And it's all very well kind of rushing to make it all right when it's a bit too late. And in some senses, it's fine to have all the electronics, but the fact of the matter is we need to talk to each other as well, and we need to make absolutely sure that that takes place. And so the process for London that we're looking at, and it is to embed this in Coordinate My Care, because Coordinate My Care, as Catherine said, has all of these elements within it. And as the system that's being utilised becomes more sophisticated and it's tuned up more and more, and connectors will start to appear between systems, there is the ability to load onto CMC portable document format, and so you can actually have forms that are linked to CMC, and you could have that form printed out so there was something in hard copy. Because the majority of people are fairly clear that even though you have electronic things, you do need a piece of paper somewhere, because often as not, when you need things the most, the middle of the night or something like that, there happens to be no signal in that area if you're using web access or something such as that. So there has to be paper backup in some way. And there is a view generally that DNA CPR forms, even if someone has an advance refusal for life sustaining treatment, there needs to be an explicit CPR form as well. And that is to take account as much as anything of the clinical governance. So whilst I've said this is to do with clinical practice, yes it is, it's also to do with clinical governance, but we need to understand that they are two slightly different things, but they do need to be working together very, very clearly. And so what we've started to work on, and a group of us about a year ago had an initial meeting, and then we had email dialogue and so on and so forth, and we came out with a draft of what a connected document might look like between two organisations. And we produced what we believe, and nobody has yet said it isn't, a relatively neutral connector which says you are responsible when you are the sending organisation. Your responsibility lies with that patient until that patient hits the next place and the next responsible clinician is able to take over. And it then puts on the responsible clinician duties about communication and about ensuring things that take place. But those two people need to know who they are, they need to know why they're that, and they need to know what those responsibilities entail, and clarifying things like handoff is really important. And through that, I guess, paperwork is the most important. Long stop, instant recognizability I've mentioned. The idea of a template I've mentioned as well. Most of you who don't get out much and fiddle around with electronic data and databases and software will know now that you have things called writable PDFs. And that enables you to fill in a PDF, which historically you couldn't do, electronically and print it out. It means you could also populate a PDF with your own data set if you wanted to. So we are in a position now where we could actually say there needs to be a consensus. We need an agreement over however large a population we agree it should be. I believe personally the Resuscitation Council and the BMA and people should lead the way on this, and meetings I've had with those organisations indicates they probably want to, is that we could actually come up with an agreed, instantly recognisable template, which doesn't have necessarily to be in colour, but is somehow instantly recognisable. And that's a task that we need to work on. One of the clear things we've also said is that actually being on an end-of-life care pathway like the LCP, by definition, commonsensically, is coterminous with and the equivalent to a DNA CPR form. Our gentleman, Mr. Beat, wasn't on an LCP, but actually people who are on LCP sometimes find themselves being resuscitated if there isn't a CPR form there. And then there are two other things. That is organising and working with the coronial services. And if you think working with health and social care and between organisations is difficult, you try and persuade a bunch of coroners to think that they want to interpret the law the same way. It's not easy. But coronial services have produced joint documents, and the exemplar example comes from Manchester, which, as you will recall, was the residence of a certain Dr. Shipman. So if Manchester's coronial services can agree what they call an expected death and how to handle it, then surely we can adopt or develop something similar. But there's a piece of work that needs to take place with the coroners and with the Metropolitan Police around London to look at that. The Midlands have taken a very different approach, but just as effective a one. You might imagine the Manchester one is absolutely rigid and set solid for good reason. And also, of course, the climate and culture in the inner city is different from rural areas where people may not need to have the same suspicions, perhaps one should say. And then really on from that is the next question, which I think is still open to debate, although it's something that I'm very committed to, and that is the development of, if you like, emergency healthcare plans, treatment escalation plans, and so on and so forth, where actually it becomes our habit that we are recording what to do with somebody or what somebody would like to be done with themselves to be more accurate under certain circumstances that we can reasonably anticipate. Now, this has been in existence in child and teenage care in particular for many years with the long-term conditions. Treatment escalation plans, emergency healthcare plans are the norm. And those existing alongside CPR forms are important because, of course, if you've got a complex neurological complaint, you may treat a respiratory arrest very different from treating a cardiorespiratory arrest. So you may resuscitate somebody under one circumstance but not resuscitate them under another. If somebody's midbrain just packs up for a moment, they stop breathing, that doesn't mean they're going to die. It means their midbrain's going to wake up in a tick, but you need to do something in the meantime, for example. Exemplars of these exist as well. And just really to give you some examples here, the northeastern may or may not be adopted across the north of England has produced a care planning based approach to CPR and everything, which is embedded in the areas that are logical and important, and that's called Deciding Right. You can see that on their website now, but we will have links to that from the national website. And I would be keen that we adopted something along those lines in London, but I'm open to persuasion. Just an example here from the South Central, which was one of the earliest places that adopted a regional approach. This is one of their emergency healthcare plans, and it applies both to children and to adults. So you've got here various information about the patient behind there on one sheet, and then here, I think they've got 3. You can have as many sheets as you want of specific clinical circumstances in which somebody may or may not want to take a particular action. Clearly, if you're not resuscitating, you want a form just saying, don't resuscitate this person. You don't want to say, excuse me, can you just stay alive for 5 minutes whilst I read the paperwork? There's got to be a simpler way of doing it than that. And then the far more universally recognizable type of DNA CPR form, and this is the example from the north east of England, and they have got a particular bit, which I've just enlarged for you there, and that says, if you die in transit, first of all, it says if an individual is returning to their preferred place of care, in other words, if this person's going home to die, that's enough for you to do a couple of things. One is no arguments, it's a Category 1 ambulance, i.e. it's an ambulance with paramedics in it. And number 2, and then you can get a 2-hour response, by the way, if you need to discharge somebody quickly. And if something happens on the way, they can be looked after, syringe drivers can be managed, etc., etc. And then if something happens on the way, do you return the person to the original destination, the journey start, or do you A&E, or do you contact so-and-so or so-and-so for further advice? So very simply, on a single side of A4, you can get all of this information in. And of course, if you if you have tiny boxes, you need it to be filled in electronically rather than scruffy writing like mine, which never fits inside the box and you probably can't read anyway. So this idea that we get onto electronic ways of doing this is clearly going to be the way forward. So those are the aspirations that we have in London, alongside, and Nigel will be talking about pathways and so on in a moment, but linking the work on pathways with the London work and CPR and so on is something that we as a group in London will be taking forward and hopefully offering some leadership in those developments. Okay, thanks very much.